Now, the ACCOAST trial was a trial that looked at the benefit of prasugrel given immediately upon diagnosis to patients with non-STEMI MIs.
Yeah, the idea here is that if you've got a non-STEMI and you're going to the cath lab and you're going to be investigated, should you wait until you get in the cath lab to give the 2B3A, to give the thienopyridine, or should you give it upstream as soon as you know about it? And this trial, importantly, did not send people urgently to the cath lab, but it was between 2 hours and 48 hours that they had to go to the cath lab. Now, when they got there, some of them, most of them underwent PCI, but some did not. So the randomization was between upstream half dose, that is 30 milligrams of prasugrel, versus no prasugrel. And then when they got in the cath lab, if they're going to have PCI, they got the full 60 milligrams in the patients who had not received it, and the ones who had received the 30 milligrams got another 30. Well, it turned out that this preloading, as you will, did not make a difference in the efficacy endpoints, the ischemic endpoints. There was an increase in bleeding with the pretreatment. And there are a number of ways you can think about how that might have happened. Maybe there was more antiplatelet effect at the time of the cath. Most of it was related to PCI bleeding. But patients, for instance, who were treated medically also had more bleeding in the pretreatment group, perhaps because they're the only ones who did receive the thienopyridine. They received the 30 milligrams upstream, but at the time of the cath, if no PCI was done, then no more 2B3A, no more thienopyridine was given. So I think it's interesting. I don't know that it's going to be game-changing in any way.
Yeah, there's been this persistent question that could you get benefit in these patients with non-STEMIs in whom PCI was going to be delayed if you immediately gave a thienopyridine. The other side of the coin, of course, has always been that if you give a thienopyridine and then it turns out that surgery is indicated, well, then you've got a delay of several days at least while the effect of the thienopyridine disappears. This study would suggest that the benefit of giving a drug early probably is not worth it, and if there's a likelihood that the patient might go to surgery, perhaps that could be held.
And I think one of the reasons for that is we have such improved stenting technology now, and also the patients who urgently needed to go to the cath lab were excluded.
They went anyway.
Yeah, so these are people who had non-STEMI, but they had settled down to some degree because they could only get into this study if it was 2 to 48 hours later that they were going to the cath lab.